Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Thank you for joining me, and also thank you for watching this if you're watching this on replay. Today's session is about how long can a patient be on BiPAP before needing intubation. Also, can you please type a 1 into the chat pad if you can hear me loud and clearly? Please let me know that you can hear me loud and clearly. Type a 1 into the chat pad, making sure you can hear me loud and clearly. Okay, so again, today's topic is how long can a patient be on BiPAP before needing intubation? This is a question we get quite frequently from our viewers and listeners and readers and clients at intensivecarehotline.com. And that's why I thought I'll dedicate a show to you, to this topic. And if we have time, we still go through some questions that came in during the week, some other questions that came in during the week. And I can also get you live on the show if you have any questions regarding your loved one in intensive care or with intensive care at home. We can do that as well. We have regularly people that come on the live stream here and ask their questions, or they type the questions into the chat pad. So before we go into today's topic, what makes me qualified to talk about a topic like how long can a patient be on BiPAP before needing intubation? So I'm a critical care nurse by background. I have been working in critical care for over 20 years in 3 different countries, nearing 25 years this year. In 3 different countries. I have also worked as a nurse manager in intensive care for over 5 years. I have been consulting and advocating for families in intensive care for over 10 years here at intensivecarehotline.com. And you can look up our testimonial section as well as our podcast section for testimonials. And I can say without the slightest hint of exaggeration that we have saved lives for families for patients in intensive care through our consulting and advocacy. That is without any exaggeration at all. You can listen to some of the podcasts we've done with clients where we help them save their loved ones' life. I'm also the founder and managing director of Intensive Care at Home. You will find more information at intensivecareathome.com. With Intensive Care at Home, we are sending critical care nurses into the home for predominantly long-term intensive care patients, predominantly long-term ventilated adults and children with tracheostomies, also adults and children on BiPAP, CPAP without a tracheostomy, but also for adults and children that have a tracheostomy and that are not ventilated. We also provide home TPN, home IV antibiotics, home IV potassium and magnesium infusions, port line management, central line management, PICC line management, and Higgman's line management, as well as palliative care. We're also providing level 2 and level 3 NDI support coordination for intensive care at home. We are currently operating all around Australia with intensive care at home in all major capital cities, as well as regional and rural areas. We are NDIS accredited, TAC in Victoria, ICAR in New South Wales, and NIISQ in Queensland, as well as DVA around the country. We have also received funding through public hospitals, departments of health, as well as private health funds. So without further ado, let's go into today's question. How long can a patient be on BiPAP before needing intubation? So many patients go into ICU on BiPAP, often for respiratory failure type 1 or type 2, but it can also be a pneumonia, can be COPD, asthma, which COPD and asthma fall under respiratory failure type 2, could be, other issues as well. However, in a nutshell, that's why patients need BiPAP in intensive care, respiratory failure type 1 or type 2. What is BiPAP? BiPAP, again, stands for bi-level positive airway pressure. it's ventilation applied with a mask and not with a breathing tube in the throat, it's generally much easier to tolerate compared to a breathing tube and intubation. Patients, generally speaking, don't need to go into an induced coma, right? And they can tolerate the BiPAP. It's also good that BiPAP can be taken on and off. If someone has a breathing tube and is in an induced coma, you can't just take the breathing tube in and out, but you can take the BiPAP on and off. Obviously, it's all dependent on, can a patient in intensive care tolerate the BiPAP being taken off, or does it need to stay on all the time? Okay, so now some of you might have heard of ChatGPT, which is, artificial intelligence. You can type in questions and ChatGPT will spit out the answer. And that is actually what I've done. I've typed into ChatGPT, how long can a patient be on BiPAP before needing intubation? I'll read out to you what ChatGPT says, and then I will show the limitations of ChatGPT and also how we can expand much further beyond ChatGPT. So, ChatGPT says the duration a patient can be on BiPAP, which again stands for bilevel positive airway pressure, before requiring intubation depends on the underlying condition, the severity of respiratory distress, and individual patient response. BiPAP is often used for conditions like acute respiratory failure, pneumonia, or exacerbation of chronic obstructive pulmonary disease, COPD. ChatGPT leaves out asthma, for example, here. Anyway, it continues. Patients may be successfully managed with BiPAP for varying durations, ranging from a few hours to several days. However, if the respiratory distress persists or worsens despite BiPAP, or if there are any signs of deterioration, healthcare providers may consider intubation to provide more advanced respiratory support. Ultimately, the decision to intubate is based on the patient's clinical status and the healthcare team's assessment of the effectiveness of non-invasive ventilation in addressing the underlying respiratory issues. So BiPAP is actually non-invasive ventilation, right? Okay, so Muneka, thank you so much for your questions. I will get to them as soon as I finish talking about today's topic. Then I will get to your questions, Muneka. Thank you. All right, so the other question is, how long can someone be on BiPAP? Look, from my experience, it really depends. It can range from hours to days to weeks and months. And the reason I'm saying that is we have clients at home with intensive care at home that are on BiPAP for years, right? On the lower end of the acuity, we have patients at home on BiPAP with sleep apnea that don't need a critical care nurse. BiPAP can also be used for sleep apnea, right? For otherwise healthy people. However, here we are talking about BiPAP in intensive care for respiratory failure type 1 or type 2. So I have seen patients in intensive care for BiPAP for weeks, sometimes even for months, sometimes for days, sometimes for a few hours. For example, when you take the breathing tube and you extubate someone, sometimes patients need to go on BiPAP just to help expand their lungs for a few more hours, making sure they can stay off the BiPAP and can stay off the ventilator, more importantly. And it's a good aid to keep patients off the ventilator and the breathing tube to begin with. What BiPAP does is it prevents the lungs from collapsing, right? Picture this, right? Let's just say someone has been intubated for a few weeks, few days. Their lungs are at risk of collapsing. Now you take the breathing tube out, they're coming out of an induced coma. They're very weak, they're deconditioned, and they can't breathe properly. They can't take deep breaths because their muscles are weak. The BiPAP is a very good treatment option to get the lungs expanded and, get the lungs expanded and prevent pneumonia and help patients to get better. Okay, let's look at some of the intricacies when it comes to BiPAP in intensive care and how it helps prevent intubation in many cases, not in all cases, but in many cases. So the first thing that you need to assess is obviously the tolerance level for the BiPAP. Can patients tolerate it? For example, one of the contraindications for BiPAP is if someone has facial fractures, has a nose fracture, right, has a jaw fracture, right, a cheek fracture, whatever it might be, or even a skull fracture, right? Because the BiPAP mask often covers the whole face. There are exceptions to the rule. There are also nasal pads now that are much more easier to tolerate. But, you know, if there are facial fractures, it could be a contraindication for BiPAP, and then you might need to go to intubation straight away. Now, furthermore, what if patients go off the BiPAP because they simply need a break, they're exhausted, they want to have simply a face wash, they simply want to have a drink of water, they want to have their teeth brushed? What's the alternative? Well, the alternative often is high-flow nasal prongs, okay, high-flow nasal cannula. It's sort of a good alternative, but again, depending on the severity of respiratory failure, high-flow nasal prongs might not be enough to maintain oxygen saturations above 92-94%, right? It also, high-flow nasal prongs or high-flow nasal cannula might also not be enough to keep the CO2 down. CO2, also known as carbon dioxide. For example, if someone has type 2 respiratory failure, it's often correlated with an increase in carbon dioxide or CO2. BiPAP will get the carbon dioxide down usually pretty quickly, right? Here is another reason why you want to use BiPAP for someone with a high CO2, if they can tolerate it. If the CO2 keeps rising and carbon dioxide keeps rising, patients get confused. And the more confused they are, the higher the chances that they will need intubation because they can't follow instructions. You know, they might have the inability to swallow all of a sudden, you know, then they aspirate, you know, they can't cough. There's a long list of complications that can happen if someone is getting confused or agitated. Okay, so next, when someone is on BiPAP, one of the most important things to look for is to do regular ABGs or arterial blood gases. In the ABG, you can assess how effective is the BiPAP, i.e., what's the PO2, also known as oxygen levels in the arteries, and you can assess what's the PCO2 or the carbon dioxide in the arteries. Either of that needs to be within a certain limit. So if you have the BiPAP on and all numbers look good in the arterial blood gas, that's a good sign. But what if you take BiPAP off only for half an hour and then you do an arterial blood gas and your blood gases have deteriorated to the point where you need to put the BiPAP back on, or potentially, you know, intubate because patient can't breathe, you know, is distressed, is exhausted, you know, that's when you need to think about intubation. Other things you need to look for is what do chest x-rays show? You know, what do CT scans of the chest show? You can easily see in a chest x-ray, you know, are the lungs collapsed? Is BiPAP working? Is BiPAP effective of opening up collapsed parts of the lungs, right? Here is another risk when someone is in ICU. One of the risks is clearly that if you don't mobilize patients, you know, they might end up with a pneumonia. So keep in mind that if someone is confined to the bed and lying on their back, right, it's very easy for lungs to get collapsed if you don't mobilize patients, if you don't give them the pressures they need, i.e. the BiPAP, right? So BiPAP can be very, very effective without the added on complexity and complications of a breathing tube and an induced coma, right? So what other risks are there with BiPAP that potentially can push someone towards intubation? Well, other risks are clearly, you know, many patients on BiPAP, not all, can still eat and drink while they're on BiPAP. Okay, you can take the BiPAP mask off, you can give patients food and some water or whatever the case may be. But here's a high risk. When someone is on BiPAP and they eat and drink, or they have a nasogastric tube, and you want to give them food or nutrition, one of the challenges here is that they are at high risk of aspiration, right? So a lot of pressure and air is going into the lungs, but also into the stomach. That's inevitable. and that can bloat the stomach, leading to vomiting, bloating, and that could lead to an aspiration pneumonia, inevitably pushing someone to intubation, right? So how can that potentially be avoided? Well, one of the ways to avoid it is to look at TPN, right? TPN stands for total parenteral nutrition. It's also known as IV nutrition or intravenous nutrition, right? So, because it is important that critically ill patients in intensive care get nutrition, they need to have the strength and the stamina to fight the critical illness, right? And not giving them nutrition is not really an option. So you can see the risk is high for someone on BiPAP to have oral food or water intake, but the risk is also high to have nutrition through the nasogastric tube, or some BiPAP patients might even have a PEG tube. Very few of them would, though, but the risk for aspiration is high. So therefore, you might have to look at TPN, especially if BiPAP ventilation is prolonged. And I'm talking about more than 2 or 3 days. I'm talking about a week at least. Then you need to look at TPN. So what's TPN? TPN, once again, is total parenteral nutrition. It's also known as IV or intravenous nutrition. The challenge there with TPN is that patients need to have a central line or a PICC line, okay? And if patients need to have a central line or a PICC line, there is a higher infection risk, right? But not getting nutrition is not an option. Bear in mind, a lot of patients in ICU have a central line anyway because of IV medications they need to get. Sometimes they need to get inotropes, vasopressors. Sometimes they need to get IV antibiotics. They need to get sedation, especially when patients are intubated, which is what we're trying to avoid here, on this call, to look at how can intubation be avoided, right? So, what's also important when someone is on BiPAP is that they get humidified oxygen and humidified air, right? So that it's running, that the BiPAP is running through a humidifier, okay? So then what is also important, like I mentioned in the beginning, BiPAP tolerance is what needs to be assessed. It can be very uncomfortable. So when I first started working in intensive care, and we had study days about ventilation, how does a ventilator work, different forms of ventilation, and so forth. Now, one of the things that we did there is put a mask on ourselves with just a PEEP of 5. Now, I can tell you how that feels. It feels like if you've got your head outside of a car window while you're speeding at 100 miles per hour. So can you imagine you've got the BiPAP mask on with high pressure? It feels extremely uncomfortable, right? So that inevitably brings up the question, do patients therefore need sedation or pain medication? Well, ideally you want to avoid sedation as much as possible, because if you're giving sedation while someone is on BiPAP and you take them off the BiPAP, they might stop breathing and then need intubation regardless. The same with opiates. If you give morphine or morphine or fentanyl for discomfort while patients are on BiPAP, again, one of the main side effects for opiates is respiratory depression. Now, the last thing you need for someone on BiPAP is to have their respiratory drive inhibited, because again, that will inevitably push them towards intubation. Inevitably, So avoid that as much as you can, right? Another thing that is important in those situations is, again, physical therapy, breathing exercises, coughing exercises, good nursing care. Patients need a regular wash. They need regular turning. The last thing you want is for your loved one to end up with another pressure sore. Okay. Another thing that can happen on BiPAP is that patients end up with a pressure sore on their face, especially around the nose, the bridge of the nose, right? Because when the BiPAP mask is on with a strap, there's a lot of pressure, right? So Often a Comfeel or a Duoderm dressing will help on the bridge of the nose. Sometimes Mefix on the side of the chin will also help, depending if you're using a full face mask or if you are using a nasal pad. Okay, so, but the biggest way to avoid intubation really is by, keeping the BiPAP on as much as possible, assessing arterial blood gases, assessing the tolerance level, looking at chest X-rays, potentially CT of the chest. Mobilization is important. Nutrition is also important because, as much as the BiPAP helps to open up collapsed part of the lungs, it is incredibly uncomfortable. There's incredible discomfort, right? And you need your loved one needs the nutrition to get stronger, right? And again, imagine you're lying in bed all day. That helps, that contributes to the lungs even more collapsing. And imagine your loved one can sit on the edge of the bed just for a few minutes, can get a good backwash, and that's how the lungs can expand. That's a very good combination, with a BiPAP in particular. Okay, other things that need to happen is, especially when it comes to things like, infections, does your loved one need IV antibiotics, IV antivirals, antifungals, depending on, is it a fungal pneumonia, a bacterial pneumonia, is it a viral pneumonia, if it is a pneumonia, and if it's not asthma or COPD, for example. What's also very important is that, your loved one gets turned from side to side, gets regular pressure area care. But also what is important is when you have someone on BiPAP, again, for type 1, type 2 respiratory failure, I just explained about the risk for collapsed parts of the lungs. By turning from side to side, again, that gives the lungs a higher chance to open up, right? Another thing that the ICU nurses can do when your loved one is on BiPAP is, if your loved one has difficulties getting up secretions, coughing up secretions, another thing that the ICU nurses can do is do a deep suctioning through the nose, right? Now, don't get me wrong, that's going to be very uncomfortable, can be very distressing as a matter of fact. But if your loved one is struggling with getting up the secretions that need to come up to open up the lungs, then deep suctioning will help, but it's also very uncomfortable, but it's also very effective most of the time. Okay, you need to go through the nose into the lungs with the suction catheter. Very uncomfortable, but very effective. Okay, so do you have any more questions in regards to how long can a patient be on BiPAP before needing intubation? If there are no other questions, then I would like to wrap this up for today and go to the questions that we're getting here from Muneka and also other questions that have come in during the week. If you have any other questions regarding today's topic, please let me know and type them into the chat pad, or you can also get live on the show here now by clicking on the link that I'm just posting here into the chat pad. If you want to come on live on the show, you can do so by clicking on the StreamYard link here, and then you can come on live on the show and join me here. Okay, and you don't need to go on camera if you don't want to. You can just talk to me without getting on camera. It's up to you. Okay, so let's go to Muneka's question. You say, "Hi Patrick, my dad has not woken up from cardiac arrest. It's been a month. They put a tube in his throat and another one in his stomach for feeding. He's been transferred to a healthcare facility in Virginia. I am worried, not knowing what to do, or think my dad has no insurance. We couldn't find a closer place to my home to be transferred to because other places are expensive. They don't take Medicaid. What can I do? He has been accepted at his care facility, which is 4 hours away from our house. Wow, I'm so sorry to hear that, Monica. Okay, let me ask you a few more questions because it's not quite clear. Let me ask you a few questions here, Monica. Does your dad have a tracheostomy? That's number one. Obviously, you are saying he's got a cardiac arrest, or he had a cardiac arrest, right? Why is he not waking up? I mean, has he sustained a hypoxic brain injury? Right? So if you can give me a little bit more. Okay, so he's got a tracheostomy. Is that what you're saying? He's got a tracheostomy. But has he sustained a hypoxic brain injury? Can you answer that with yes or no if he sustained a hypoxic brain injury? He has been diagnosed with global hypoxic brain injury. Okay. Okay. It's been a month. Okay. Is he getting rehabilitation, physical therapy? You know, what does his day to day look like, or is he just confined to his bed? He moves his lips, opens his eyes rarely. I see. Is someone actively stimulating him? Is he getting... No, not yet. I see. Well, you see, Monica, that's not good enough as far as I'm concerned. Here's what I can see in a situation like that. Confined to his bed, yeah. Here's what I can see. For someone in a situation like your dad, he should get mobilized. He should get physical therapy. You know, people should try and move him forward, move his condition forward, right? And they're not doing it. It looks like they're only focused to sending him out. So, you know, for them, it's like out of sight, out of mind. But I believe that's not good enough. And you know it's not good enough. So by sending him somewhere else, he will only go from bad to worse, especially since, you know, they've accepted him in a care facility, which is 4 hours away from you. That's not acceptable. So here's what you should do. First off, he cannot go anywhere without your consent, right? It's as simple as that. I'm assuming you are the power of attorney. I'm assuming that, right? But he cannot go anywhere without your consent. That is number one, right? Number two, if I was you, I would buy some time, right? I would buy some time and say to them, well, I need to have a look at more than one of those facilities. And ideally, I would need to look at more than one of those facilities that are much closer to me. Right. So you are potentially not the power of attorney. Is that what you're saying? Okay. All right. Let me ask you this. Who gave consent to the tracheostomy and who gave consent to the PEG tube? Someone must have done. Was it you? Because if it was you, then I argue you are the power of attorney. You just don't know it yet. Right? If you can let me know who's given consent to the tracheostomy and to the PEG tube. Your sister, I see. So your sister must be power of attorney there. Yeah, okay, fair enough. Are you and your sister on the same page in what you want to achieve for your dad? Because that is really important here. You know, are you and your sister on the same page? In the meantime, what I will say is you will need to look at more than one facility, right? And You will need to look at more than one facility. And you need to look at those facilities that are closer to you. So kind of your sister and you are on the same page, kind of. Okay. All right. I think that is really important. So other question, Muneka. Do you have access to the medical records? Do you have access to the medical records? While I'm waiting for your answer, get access to the medical records. And once you have access to the medical records, then you need to let them know you want the second opinion. There's not really any more facilities near my house. Well, that's all the more reason to keep him where he is. Are you happy with where he's at the moment? Do you think he's getting good care where he is at the moment? Do you think he's getting good care where he is at the moment? Yep, your sister has them. Okay. So, because what will happen is, we could look at the medical, or we can look at the medical records. And when we look at the medical records, we will find reasons why your dad shouldn't go anywhere. Most patients bounce back from care facilities to ICU within no time. He looks stable. Okay. The question is he stable? We will find out in the medical records, or I can find out by talking to the doctors and nurses directly. He's no longer in ICU. Okay, where is he? Is he in a step-down ICU? In either case, what needs to happen here, Muneka, is he needs to get mobilized, he needs to be stimulated, and he needs to be in an environment where he can be rehabilitated. And one way to rehabilitate him is getting him to a neurology rehabilitation facility. Right? That's where he probably should go as a next step. He's in a step-down ICU. Yeah, okay. All right. Look, Muneka, the problem here is for them, it's like out of sight, out of mind. So let's just run through what I consider a worst-case scenario. Let's just say your dad goes to this facility 4 hours away from home, 4 hours away from where you are. And his condition deteriorates, right? And he needs to go back to ICU, which often happens. Then he will go to an ICU that's also 4 hours away. So he's going from team to team to team to people who don't know him. He needs consistency. He doesn't need new teams every couple of days because people no longer want to look after him. Right? Real challenge here. A real challenge here. Have you spoken to a neurologist, Muneka? Have you spoken to a neurologist? Because a neurologist will probably be the closest to an accurate diagnosis or prognosis as well than anybody else. ICU is focused on, I am saying he might go back to ICU. And the reason I'm saying that is most LTACs have very few skills, very little skills to wean patients off the ventilator, rehabilitate them. It's like the beta version of a nursing home. Right? It's like the beta version of a nursing home. Muneka, if you want to, it might be easier if you just join me on the call. It's up to you. I'll just post the link here again. It might be easiest if you can talk to me here. You don't need to go on camera. He didn't give us a lot of hope. The neurologist didn't give you a lot of hope. Okay. Right. How old is your dad? Can you give me your dad's age? Okay, so, this is what it comes down to. 63, so not very old. Oops, not very old. As a matter of fact, he's very young. So, how to go about not sending him, to that facility? Well, simply tell them he's not going anywhere. Now, I can't talk about insurance here, but I tell you what I do know about insurance. Many times the hospitals bluff and they say, oh, insurance won't pay beyond a certain date. Well, that's what the hospitals often say. I would not trust that. And if the insurance is not contacting you or your sister directly, I wouldn't bother about it. I wouldn't, right? And I would just carry on and keeping him where is it is already for Monday. I don't know what you mean. Is he scheduled for a transfer on Monday? Is that what you are saying? But even if he is, it's never too late. It is never too late to challenge this. Never too late. Right. It's never too late to challenge it. What I would do if I was you is I would send a letter here to hospital executive and challenge it on all levels. A, they can't get him anywhere without your consent. For example, if I was you, I would ask them for the hospital discharge policy. The hospital discharge policy most likely would say something like, well, he can't go anywhere without your consent. Very simple, right? Very, very simple. Do not overcomplicate here. Challenge this on any level. Ask them for the hospital discharge policy, right? And tell them that he can't go anywhere without your consent. And like I said, don't worry too much about the insurance. If the insurance hasn't contacted you directly saying, oh, we no longer pay for step-down ICU, I wouldn't worry too much about it. It could just be ICU wanting to put pressure on you. Why would the insurance not contact you if your dad was running out of insurance entitlements? Why? Here's another thing. If your dad does go to this facility and God forbid he goes back to ICU, right, they will pay for another ICU bed. Right? So there's a lot of variables here. And I wouldn't get too sidetracked about their pushiness. I would focus on what you want. That's what I would focus on if I was you. What do you mean step down ICU? So, well, you are saying here he's in a step down ICU. You've said that he's in a step down ICU just a few minutes ago. That is what you said. Right? But one way or another, and also an LTAC, because it's just sort of the better version of a nursing home, if that, right? They don't have ventilator and tracheostomy competent people. They don't, right? And because they don't have the skill set, it'll be very difficult for your dad to progress further. Whereas here, where he is at the moment, hopefully he's got all the skills he needs to move forward. Sorry, looks like second floor. Yeah, but what's the second floor? What is it? Is it step down ICU? What is the second floor? What is that? Is it a telemetry unit? Is it step down ICU? Is it HDU? Is it high dependency? And I hope you can see why, if I was you, I wouldn't go anywhere without you having looked at this other facility. You need to look at it. not sure. Okay, you're not sure about where he is. But you can't just send him blindly to another facility. It'll end up in disaster if you don't do your research. Also, have a look online what the online reviews are for patients that have gone to this particular LTAC or to any LTAC for that matter. Right? The online reviews are not good. They're terrible. Your sister said it's a closer one. Yeah, but 4 hours away is not acceptable. Your dad will need his family around him. It's not acceptable. Okay, I think you need to change your mindset here. You are too worried at the moment of what they want to do. And I'm not saying just push it aside completely, but you need to shift your focus to what you want. Now, I'm not sure whether you are clear on what you want. You're saying your sister says they take patients with that condition. Okay, all right. Are they specialized in neurology rehab? Are they specialized in hypoxic brain injury? Right? Because if they're not, what's the point? Are they specialized on weaning someone off a ventilator and a trach with a hypoxic brain injury? That's what it comes down to me, from what I'm understanding. Because if they're not, you're wasting your time. If you're going to another facility, you need to be 100% sure that's the right step for your dad. Right? You need to be 100% sure it's the right step for your dad if he's going to that other place. You can't just blindly go to another place. That could be a disaster waiting to happen for you and for your dad. Right? Let me ask you another question. Do you feel like your dad is in a good place at the moment? Do you feel like he's getting everything that he needs at the moment? Because if you do, why would you get him somewhere else? That would be sheer madness. Right? Hospitals are very good at telling families, oh, we are going to do this and we are going to do that, and there's nothing you can do. Well, there's a lot you can do, but you actually need to do it. Right? I can't do it. Well, I can do it for you if you employ my service, but there's a lot you can do if you try. Right? That's what it comes down to. You haven't tried. You've been too passive, from what I can see. What I would do is this. Once again, let's look at some action steps here. Have a look online what's documented about online reviews for the facility that they want to send your dad to. Kind of feel like they're putting the pressure on my sister that he needs to be moved. Yeah, I'm sure that's what they do. I'm sure that's what they do. Of course, that's what they do. But you need to turn that around and put the pressure back on them and say, no, that's not what we want. Right? There's nothing unreasonable here, Muneka, by you requesting that you need to look at the other facility first. There's nothing unreasonable in that request at all. There's nothing unreasonable in you saying, hey, I have to look at some of those other facilities that are closer to me, right? There's nothing unreasonable in you saying, hey, I want to keep my dad here until I'm clear what I want to do next. And there's nothing unreasonable about saying, hey, I want to keep my dad here and move him forward. And you make sure you are, giving him what he needs. He gets rehabilitation, he gets physical therapy, he gets mobilized. There's nothing unreasonable in that whatsoever. And I can tell you from my experience, if the health insurance has not contacted you or your sister saying, hey, your dad is running out of entitlements, I argue they're just bluffing. I can tell you from experience that If there's an insurance problem, they will contact you. The insurance will contact you. If you or your sister haven't heard from the insurance, I wouldn't worry too much about it. I wouldn't. So sorry, we got distracted by action steps because you were typing another message. So once again, action steps. You need to look at other facilities first, right? Have a look at online reviews. Ask for the hospital discharge policy, right? If they're not giving you the policy, you know what's in there. Because if they're not giving you the policy, it'll say, well, the patient can't go anywhere without power of attorney consent, assuming the patient can't make decisions himself, which it sounds like he can't, right? So then, next, insurance-wise, I argue if the insurance hasn't contacted you directly, it's just hot air. Now, can I be sure about this? No, of course I can't, but 9 times out of 10 from my experience, they will contact you directly if there's an issue, right? Next, your dad won't improve if he's not getting neurology rehabilitation. He won't. Very unlikely, you know. And keep in mind, in the bigger scheme of things, you mentioned it's been a month. Now, I can tell you a month is not a long time. A month after a situation like that is not a long time. And I know it probably feels like an eternity for you, don't get me wrong. Feels like an eternity for you, I can imagine that, right? But do not let the pressure from the hospital stop you from advocating for what you know is right for your dad. And don't let the pressure, and I call it perceived pressure from the hospital, dissuade you from advocating for what you want for your dad, what you think is right for him. You know, it's pressure, and most 99% of families respond to that pressure. Well, you don't need to respond. This is something you control. You control if you respond to that pressure or not. You can't control other people, but you are 100% in control how you respond, right? And all of our clients get results because they follow what we teach them. Push it back on them. You need to push it back onto them. Right? You also need to look at, let's just say you are getting into another place, you need to look at success rates. What are their success rates? What are the patients and the families saying about those facilities? And I bet when you look up online, the reviews, they're not saying, most families do not say anything nice about them, unfortunately. Right? And then other action step is write a letter to hospital executive, summarize the thing that I've said here, right? Other things that you can do, again, where we can help you is look at medical records and get a second opinion and say, we will probably find things in the medical records saying there's no way your dad is ready to go to wherever. You know, other places don't take Medicaid. I don't have the money to pay. I see. And I see that can be a real issue, Monica. However, have you spoken to Medicaid? Have you spoken to Medicare? Right? Have you spoken to them? Also, here's another tip. You're saying it's been a month. Most patients, well, all patients really for that matter, who are on Medicare are entitled for 60 days of hospital stay. Right? Again, your dad is at, from what I'm understanding, around the 30-day mark. I argue you still have time. You still have time. Right? Let time work in your favor. And by that, I mean, you know, you still have time here. Here it says, you say, not me, my sister, talk to the social service. Right, right. I think one of the reasons you still have time is that Medicare pays for 60 days of hospital stay or ICU stay, right? And I argue with him still being ventilated with a trach, right, he still qualifies for hospital and ICU. Right? Other issues you have to consider is if he goes somewhere else, you know, does he still need specialist input? Bear in mind he had a cardiac arrest. Does he still need cardiologist input? Does he still need neurology input? If he does need specialist input, will he get that in an LTAC? Well, I can tell you, most likely he won't. For the hospital, it's out of sight, out of mind. That's what it is for the hospital, and you will need to put a stop to that. Other question, Muneka, where in the US are you? Where is your location? If you could share that with me. Did you say something about Virginia earlier? Just scrolling back through your questions. Through your comments. 4 hours away from my house. Oh yeah, you're saying he's being transferred to a healthcare facility in Virginia. So you must be close to Virginia. Surely there must be other places. There must be other places in, you know, wherever you are. You're somewhere on the East Coast. There must be other places that are closer to your home that take Medicaid. Right. Okay, I hope that makes it clear, Muneka, what you need to do next. We're here to help you. You know, obviously, if you wanted us to look at medical records, if you wanted us to look at your dad's case further, you know, we do charge a fee for that. But, you know, I think I've given you enough here to get the ball rolling. I think the biggest leverage point here is for you to write to hospital executive, ask for the medical records, talk to Medicare and to Medicaid. Keep in mind, Medicare patients have 60 days at least. You've only used half of that. It's very reasonable for you to ask for a facility closer to home for you. But I strongly advise against most of those facilities because they don't have what it takes. Right? Okay, so what do I need to look into when looking for another rehab place? Yeah. So you live in Myrtle Beach, South Carolina. Right. Okay, so what do you need to look for? Are they qualified to be in patients off a ventilator and a trach? Do they have the skills to look after patients on a ventilator with a trach? What's the nurse to patient ratio? You know, most ICUs, it's 1:1, 1:2. And all of a sudden, when you go to LTAC, it's 1:10. Can you see the discrepancy? It's like day and night. And that's why patients bounce back into ICU. You asked me earlier, am I saying he'll bounce back to ICU? That is what I'm saying, unfortunately. Because patients go from 1:1, 1:2, maximum 1:3 nurse to patient ratio to 1:5, 1:6, 1:10 without staff that are ventilator and tracheostomy competent. The risk of things going wrong is huge. And that's why patients bounce back. So imagine, worst case scenario, he's going to a facility 4 hours away. He'll bounce back into ICU 4 hours away, right? I tell you what I will recommend. I recommend you advocate for him staying where he is and ask them to move his rehabilitation forward. And this can start with simple things such as mobilization, physical therapy, getting him out of bed, stimulating him, you know, simple as that. You know, you're saying in one of your comments, you mentioned he's confined to his bed. Well, why? if he's not unstable, he can get out of bed. There's no reason he can't get out of bed, right? And they will promise you, oh, he's going to another facility so he can get mobilized. Well, that remains to be seen. In the meantime, why are they not mobilizing him? Why not? What stops them? I tell you what stops them. They're lazy and they're complacent. That's what it is. So what I recommend here, Muneka, is to keep him where he is. That's what I recommend until you are crystal clear on what you want for him and until you've done your research about those other facilities. That's what I do recommend. Because generally speaking, nothing good comes out of going to those other places, from my experience. Okay, I hope that helps, Muneka. I do want to wrap this up today. I do want to wrap this up here today. I do those YouTube lives once a week, usually 6:30 p.m. Eastern Standard Time on a Saturday evening, which is 3:30 Pacific Standard Time on a Saturday. It's 10:30 a.m. Sydney and Melbourne time on a Sunday, 10:30 a.m. Sydney Melbourne time on a Sunday here, which is 11:30 p.m. on a Saturday night in the UK and Ireland. Now, we have a membership for families of critically ill patients in intensive care, where we can help you with your questions and with your problems that you have when you have a loved one in intensive care. You can get access to that membership by going to intensivecarehotline.com, click on the membership link, or simply go to intensivecaresupport.org directly. Muneka, yes, the video will be uploaded shortly and you can watch it for sure. You can watch it in replay. It should go on YouTube as soon as I press the stop button here. Yeah, your sister can see it. Absolutely. Absolutely. And you can also, it'll also go on our website at intensivecarehotline.com on the YouTube live section. It'll be there in the next couple of days. So talked about the membership. In the membership, you have access to me and my team 24 hours a day, and we answer all questions intensive care related. I also offer one-on-one consulting and advocacy for families in intensive care over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly as well. And I ask all the questions you haven't even considered asking, but must be asked in a situation like that so that you can make informed decisions, have peace of mind, control, power, and influence. I also represent you in family meetings with intensive care teams, and I assess with you whether you should even go into a family meeting, right? And I make sure you have a strategy if you do go, so that you don't get walked all over, right? I have worked in intensive care for over 20 years in 3 different countries, where I worked as a nurse manager for over 5 years, and I've been consulting and advocating for families in intensive care for over 10 years now. Go to intensivecarehotline.com, have a look at our testimonial section as well as our podcast interviews with clients, right? We also offer medical record reviews in real time so that you can get a second opinion in real time. That's exactly what I think you need, Muneka. We will find reasons why he shouldn't go to LTAC. So medical record reviews in real time, that you can get a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. All of that you get at intensivecarehotline.com. Contact us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com, and also have a look at intensivecareathome.com if you need home care for your long-term ventilated family member, adult or child, tracheostomy care at home, palliative care at home, home TPN, central line management, PICC line management, Hickman's line management at home, IV antibiotics, IV infusions, all of that you get at intensivecareathome.com. We are operating all around Australia at the moment with intensive care at home, but we also help families in the US and in the UK privately. Contact us at intensivecareathome.com or send us an email to info@intensivecareathome.com. If you like my videos, subscribe to my YouTube channel for regular updates, for families in intensive care and intensive care at home. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have. Share the video with your friends and families. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days. Take care for now.